Hi, my name is Jomy George. I am the director of the Clinical Pharmacokinetics Research Lab here at the NIH Clinical Center Pharmacy Department. Today, I'll actually be going through a case study focused on transporter-mediated drug-drug interactions. So let's get started with the patient case. This is a 45-year-old male with a medical history significant for HIV, hypertension, and left lower leg deep vein thrombosis, or DVT, who presents to clinic today with a 5-day history of recurrent nosebleeds and feeling fatigued. His current medications include the following: the antiretroviral regimen elvitegravir, cobicistat, tenofovir alafenamide, emtricitabine, given as 1 tablet by mouth daily, the antihypertensive amlodipine 10 milligrams by mouth daily, and the oral anticoagulant used to treat his DVT provided at 150 milligrams by mouth twice daily. And this started about a week ago. So when we take a look at this particular case, we need to take a couple of steps at least to identify the problem. And identifying the problem is important because we can come up with logical solutions on how to actually best manage these challenges and provide optimal care for this particular patient. So in looking at what's highlighted in red, the statement that's provided there pretty much provides a lot of information that's extremely important for management for this patient. So this individual has a medical history that has a number of comorbidities that require multiple modalities of drug therapy, which are implicated in a number of drug-drug interactions. Also of note, what's significant is that this individual presents with side effects, presumably from his oral anticoagulant that started about a week ago. And when we take a look at his regimen, his medication list, we really need to think about, are any of these particular drugs have clinically relevant drug-drug interactions? And this is important because this individual is actually presenting with side effects, again, presumably from his oral anticoagulant. When we take a closer look, in fact, there is actually an interaction between cobicistat, which is a PK booster or pharmacokinetic booster or enhancer that's provided as part of his antiretroviral regimen, and his oral anticoagulant, dabigatran. So our next step is understanding how to go about figuring out what resources we need to use to provide and help support. Is there data to support this drug interaction, and is this drug interaction clinically relevant? And could it possibly explain why this individual has developed this side effect from dabigatran? And what I've pulled for you here are 2 resources that are reputable resources, one being from the University of Liverpool and the second being from Lexicomp. And these are simple searches that were provided using their drug interaction checker online. So if you take a look at these recommendations, they're actually a little bit different. However, the data that is used to support these recommendations are similar. By the recommendations provided by University of Liverpool, as you can see here, their recommendation is actually do not co-administer these particular medications. And the data here to support it is based on a theoretical interaction that cobicistat can actually increase the exposure of dabigatran. And we'll go through the mechanism of the interaction in a few slides. If we look towards the other side of the slide where Lexicomp provides also a drug interaction checker, the actual risk here is not to actually do not co-administer, it's actually to monitor therapy and really look at the patient and understand the benefit versus risk ratio, and if there needs to be any dosage modifications or avoidance of co-administration. So having said that, let's take a look specifically at the drugs that are implicated in this particular drug interaction. So cobicistat, as I'd mentioned, is a pharmacokinetic booster or enhancer. It doesn't have antiretroviral properties per se, but its really main focus or function, if you will, is to enhance the exposure of concomitant medications, namely the antiretrovirals that are combined within the tablet. And dabigatran, as I'd mentioned, is the oral anticoagulant. When you pull data on how these drugs are metabolized or transported, you will note that cobicistat actually goes through CYP450 mediated metabolism. Specifically, as highlighted here, it's a strong inhibitor for CYP3A4 as well as a substrate for it. It also inhibits CYP2D6 to some extent. But when we take a look at transporters and the transporters that are implicated for this particular drug, we actually see a number of transporters that are involved for this particular medication, including P-Glycoprotein, BCRP, MATE1, OATP1B1, and 1B3. And these are all different functions, and these transporters are located all throughout the body in different areas. But what's important to understand and appreciate is that dabigatran happens to be a pretty sensitive substrate for P-glycoprotein. The FDA defines a sensitive substrate as one that, in the presence of other P-glycoproteins, its exposure will increase more than twofold. So in its drug development program, there is data for dabigatran in combination with other PGP inhibitors. However, it has not been studied with cobicistat. So the natural question again is this a clinically relevant interaction, and could this interaction be explaining the side effect profile for this particular medication in this patient? So let's take a closer look at the actual mechanism and really breaking down what actually is happening. What the picture here is depicting for you is the intestinal membrane, specifically in the enterocytes where P-glycoprotein is located. And P-glycoprotein, as you've learned from the lecture, is located all throughout the body. P-glycoprotein is indeed an efflux transporter, and it has its specific function and role in mitigating or facilitating transporter diffusion across different membranes. So looking at the intestinal membrane, there is an apical side, which faces the intestinal tract or the lumen, the basolateral side, which faces the blood. Now, when an individual ingests dabigatran, in the absence of any transporter inhibition or induction, dabigatran sits as a P-glycoprotein substrate. But in the presence of cobicistat, cobicistat actually inhibits this efflux of dabigatran. So essentially what's happening here is that you've got almost a stoppage, if you will, of this carrier-mediated efflux. And keep in mind that there is always this constant concentration gradient that can go from the apical to the basolateral side, which really determines the absorption or the intestinal absorption of a medication, or it can go from the basolateral to the apical side, which really determines its excretive gradient. What happens when you inhibit this particular transport? You increase the concentrations, or you actually increase the intestinal absorption and bioavailability of oral dabigatran. And what happens? You have an accumulation of the drug within the blood, which then really translates to higher concentrations, higher exposure of the blood. But again, the question is this relevant? Is this exposure high enough such that this requires a dosage modification or a recommendation in avoiding these medications altogether? So I've pulled for you here the FDA-approved label for dabigatran, and I've specifically highlighted for you the section on drug interactions. If you take a look, these labels are actually quite complicated to go through, and as clinicians, we'd have to make sure that we're looking at these medications for the right indication, and we understand what data is available, and if that data can be extrapolated to other drugs of interest and other target populations. It should be noted that most of the drug interaction studies that are included within a drug label are conducted in a healthy volunteer population and not within the target population. So things to consider are other patient covariates that are not actually accounted for in the actual clinical trials. So what this section actually outlines for you are particular recommendations based on the absence or presence of the concomitant medication that could be interacting or interfering with drug transport. It also highlights for you in the presence of kidney dysfunction or renal impairment if those recommendations change. And specifically for dabigatran, dabigatran is actually eliminated via glomerular filtration, about 80% of it. So from a clinical standpoint, this is actually very, very important to appreciate and to incorporate into our final recommendation for this particular patient. So I'd like to focus right here where it says the use of PGP inhibitors, specifically what's called out are verapamil, amiodarone, quinidine, clarithromycin, and ticagrelor. All of these particular medications were studied with dabigatran, and the exposure, although they were increased in the presence of these PGP inhibitors, they were deemed to have, there was a margin, if you will, that was of efficacy and safety within that, for that particular exposure that was deemed to be clinically irrelevant. Or really what that means is it did not require a dosage adjustment. But what's important is the next statement also. These results should not be extrapolated to other PGP inhibitors. So then the question comes up, in this particular case, cobicistat, which happens to be a PGP inhibitor, what do you do? How do you manage this patient appropriately? Is it appropriate to continue to dose this individual in the presence of this side effect, or do we need to dose adjust perhaps the medication? And this leaves essentially a research gap in data. And in response, if you will, to help fill this research gap, there was a publication that was put out by Gordon et al. In Circulation in 2016, which really sought out to help fill this gap and to study the drug interaction impact of cobicistat on dabigatran. I should note here that the study actually looks at this particular interaction in healthy volunteers, but this is a comparison between the impact of ritonavir, which is also a PK booster, but this is an older PK booster that has fallen out of favor, namely because of side effects and because of the fact that cobicistat is now available and is better tolerated. So this particular study actually looks at both ritonavir and cobicistat. As you can see here, panel A focuses on ritonavir and panel B, or arm B, is on cobicistat. These are very simple concentration versus time curves where dabigatran plasma concentration is plotted for you on the y-axis. The time of administration, post-dabigatran administration, is plotted for you on the x-axis. Both of these arms had 3 different phases. The first phase in both arms was to provide healthy volunteers dabigatran alone. The second phase included providing or giving dabigatran 2 hours before either ritonavir or cobicistat. And the thought here is that because this drug interaction is mediated or modulated by P-Glycoprotein, perhaps separating their administration to mitigate this interaction would help in perhaps being able to provide these medications together. So that was actually studied, if 2 hours was actually enough, and if that separation actually did mitigate that interaction. And that third phase was simultaneous administration of dabigatran with ritonavir or cobicistat. And as you can see here, you can visually appreciate that there are significant differences between both of these arms. Particularly in the setting of simultaneous administration of dabigatran and cobicistat versus dabigatran and ritonavir, you can see a significantly increased Cmax and overall exposure of dabigatran in the presence of cobicistat. What's interesting though here is that actually ritonavir and cobicistat are both PGP inhibitors. So this actually speaks to what the label actually indicates as well, that the ability to extrapolate data to other PGP inhibitors may not be appropriate in all patient populations. And this really focuses and calls out that in the absence of data, extrapolation may not be entirely appropriate, and you need to take a case-by-case benefit versus risk ratio for each of your patients. So again, even though this PK study provided quantitative data, it provides you a percentage increase, it provides you metrics as far as how much the drug is increased in the setting of cobicistat and ritonavir. But again, the question is that exposure increase still clinically relevant? Would this exposure put individuals at risk for bleeds, namely? So in this healthy volunteer study, it's apparent that COBI did have a much more profound effect as a PGP inhibitor, but extrapolation of this data may not be entirely appropriate to all target populations. Staggering the dose actually did not have an expected pronounced effect. It actually did not mitigate the interaction. And likely the mechanism is that CoB is indeed a potent intestinal PGP inhibitor, whereas ritonavir may be acting as an inducer, a mixed inducer and inhibitor of P-Glycoprotein. The clinical relevance right now at this moment is really unknown. However, because our particular patient is experiencing side effects, this really cannot be ruled out that possibly the cobicistat is propagating or propitiating the drug interaction with dabigatran. The therapeutic options for this individual, really any individual, based on this PK data, is either to avoid its concomitant use altogether, provided that there is an appropriate alternative option for the patients. Second would be to space apart perhaps the medications for more than 2 hours. In the case of dabigatran, it should be noted that dabigatran is already being given twice a day in this particular patient, and really all patients. For dabigatran is typically dosed twice a day. So really spacing these drugs apart for more than 2 hours really doesn't provide a chance for patients to be actually adherent to their medications, and actually could negatively impact adherence. So may not be the best optimal choice. And then lastly, does it make sense to reduce the dabigatran dose? But the question then is, how much do you reduce the dose? And would that actually have negative impact, namely on efficacy? And remember that there's a delicate balance between efficacy and safety. This is a drug that's being given to an individual to essentially anticoagulate them after having identified thrombosis. So we do need to carefully figure out the balance between efficacy and safety, and if that reduction of dose is truly therapeutically appropriate. And for all of those reasons, this really provides or introduces many different management challenges. I've pulled for you here a number of FDA US product labels for other direct oral anticoagulants, select ones that are listed here for you: rivaroxaban, apixaban, dabigatran, and edoxaban. If you look across the drug interaction potential, actually both rivaroxaban and apixaban plausibly actually pose a higher drug interaction potential because they're substrates for both cytochrome 3A4 as well as P-glycoprotein. The label recommendations essentially provide guidance saying that with rivaroxaban, drugs like cobicistat should be avoided altogether. Apixaban, you could use it, but you may need a dosage reduction depending upon the indication for the drug and the patient population and other patient covariates. Dabigatran, we already went through the label recommendation for that, and edoxaban, which is a fairly newer direct oral anticoagulant that's available. The data actually with edoxaban, if you note here for in the product label, is that with specific PGP inhibitors, you actually might be able to use it without any dosage adjustments. But I would caution or advise that we have a patient here that's developed a side effect plausibly because of the oral anticoagulant. So the question of being able to safely administer in the presence of his antiretroviral regimen really should be questioned. And I'm not entirely sure if really switching him to edoxaban would be the most appropriate option. But having said that, we have to do something for our patient. We have to make a decision. So we did identify the relevant drug interaction. We're essentially deeming this to essentially be clinically relevant for this particular patient case, as he's developed side effects presumably from his dabigatran. And because he's feeling fatigued, remember, he could have lost actually quite a bit of blood, but we don't have other laboratory markers to really support that. But really, it should cause concern given that he has had recurrent nosebleeds, really temporally associated with the time of initiation of his dabigatran. And really, what we need to do is to think about and ask advice from specialists and really take a multidisciplinary approach in really managing this particular patient. So really, it would be great to work with his HIV provider to discontinue his cobicistat-based antiretroviral therapy and really construct an alternative regimen which poses a much lesser drug interaction risk. And in this situation, you could actually continue his dabigatran and treat him for his DVT. Or Other options could potentially be if for whatever reason he cannot tolerate or cannot be switched to an alternative antiretroviral regimen, we do need to think about switching him to another oral anticoagulant, but would need very frequent monitoring to ensure that he doesn't continue to have side effects from his oral anticoagulant. So in summary, drug transporters are implicated in many clinically relevant drug interactions. It may not be appropriate to extrapolate drug interaction data generated from healthy volunteers to a target population, or rather for a drug of interest, other drugs of interest. It is important to practice a multidisciplinary approach in the management of these patients who do present with rather complex comorbidities, which end up having very complex drug-drug interactions. Thank you, and I hope this presentation was helpful.